this morning. I am joined this morning on our program by my right-hand guy here, Dr. Dana Hawkinson, Doc Hawk, Hawkeye, whatever, Dork Brain, all right. And he is back on the program today, Medical Director for Infection Prevention and Control. We're joined this morning by one of our outstanding hospitalists, Chris Brown, MPH and MD. Chris is here today as we get in and delve into some of the issues around racial disparities and health equity and COVID. Also joined as the Medical Director for the Wyandotte County Health Department, Alan Greiner, one of our great family medicine docs, and he comes from a department that has been devoted to public health for many years, and we're happy to have him on the program. And we hope to be joined by Carrie Francis, who's a head and neck surgeon here at KU, does a great job for us. She is just finishing up in the operating room. We hope she's able to pop on in just a little bit, and we'll talk with you more to talk with her, we hope, then. Also, just a special note, this is our 51st program. If people had asked me that we were going to be doing that like this back when this whole thing started, I would have said, you got to be kidding me. And, most people would say to me that, hey, Stites, you have a face made for radio. And I think that's probably true. But here we are in our 51st episode, and so appreciate all of our listeners and all of the folks who tune in and are a part of this as we continue to have honest conversations about COVID. And that's going to continue on Monday. We have two COVID victims who will be with us on the program on Monday. One is a widow who was made widowed through SARS-CoV-2, Susan Robert, and then Anthony Nickens, a person who works here at KU, is going to be on our program along with his mom to talk about the impact of COVID on a cluster in a family. And I think that'll be a really, really important discussion. We don't have Senator Moran with us today. He'll be joining us again next week. He had an important event come up this morning that he had to be with. So, Doc Hawk, how are we?
I'm good. We are good. The hospital, the health system is good. Most importantly, I think our patients are good. So we have continued to have lower numbers this week. Currently, we are at 15 patients in the hospital. 5 of those are in the ICU, and 4 of those are on ventilators. So we have had discharges and people recovering, and that's a good thing. We have been very lucky, and we haven't seen a large surge, and hopefully we can continue to be lucky and not see that.
Yeah, I hope so too. You know, the Lake Perry story, there were 50 boats were moored together recently here on the Kansas side. Now we know at least 10 positive, and I think more I've heard, that have taken COVID to 3 other states as well as Kansas and Missouri. That's a concern, especially with what we saw at the Lake of the Ozarks and really any other mass gatherings.
It is a significant concern. Hopefully those people, haven't spread it further. With knowing the virus, that's probably unlikely. Hopefully they will not need hospitalization. We are getting to that time point now where we should start to see people, if there were ill contacts at the Lake of the Ozarks parties or anywhere else in those gatherings at different places, they should start having symptoms now. With any luck, they won't, and that would be a great thing. But I think we need to be watching for that, and people need to be aware of that we should be entering into that time now where people might be having symptoms and getting tested.
It's still so important to follow the pillars of infection control as people go back out into the community. And Chris, this has been a really important issue because we've seen, let's just be honest, the events of the last few days in our country after the death of Minneapolis. Racial disparities are real. And as a country, we have to own those. But they're also true in health. Talk to us a little bit about what you've seen. I mean, you have a public health background as well as a medical background. Talk to us a little bit about Wyandotte County and what you're seeing with some of these public health disparities that COVID is again highlighting.
Okay. And again, anytime we think about health disparities, okay, we recognize within the medical community, the public health community, that there are individuals, there are populations of individuals who tend to have or be more at risk and have poor outcomes across just medical disease in general, whether it be heart disease, diabetes, etc. And we also see that minorities tend to live within those communities, disadvantaged socioeconomically wise, and and we're starting to see, and we see those same things is COVID, meaning that we see those same things. So I guess for me, the way I look at it is that working here is that I kind of look at it two different ways. I've seen those clusters of populations, for example. Hopefully, we don't see it coming out of the Ozarks, but we've seen those clusters, whether it be nursing homes, meatpacking plants,
yeah.
etc. And right now, recently, when I was on service, I actually saw a lot of those same things with meatpacking. You have individuals who work there. They have become positive. They live within these low economic, socially disadvantaged communities, and now you're starting to see that trend and just that cycle, okay? And, but generally speaking, we also here at KU or within our healthcare system, we take care of a vast, very diverse population across all economic backgrounds, socioeconomics, as well as race and ethnicity. And outcomes, to be honest, for us at least, have really been geared towards what their underlying comorbidities were or are. But for me, what I've noticed, if you separate that going further, is how do we get some of these patients home? Meaning I've seen that we've had to be a little more creative sometimes in getting people home to those social disadvantaged homes, because it's a lot harder for them to self-isolate, self-quarantine, etc., versus someone else who's not so disadvantaged, where they have an extra bedroom, they have other ways in which they can self-isolate. And so we really had to be a little more creative and a lot more thoughtful in how we get those individuals home from that standpoint.
Yeah, those are the real struggles on a daily basis. And I know, Alan, you've worked a lot on that in Wyandotte County. You've devoted your life really to public health and to Wyandotte in a lot of ways in your professional career. Talk to us a little bit about what you're seeing in Wyandotte. I know that you had some information you wanted to share this morning.
Yeah, so I think when all this started with COVID-19, we had real concerns. Wyandotte County has had significant health inequality for decades, real significant differences in the health outcomes between those at different socioeconomic levels, but also between those of different races and ethnicities. And so we started looking at things we could do and strategies we could bring to bear pretty early on, really over probably 6 or 8 weeks ago. And so I've got way too many slides here today, and I'm going to have Logan whip through some really quickly. There's actually a Regional Health Equity Council webinar later this morning between 10 and 12 that I think we posted the registration information on our Facebook. I'm going to talk about all these things that we've been trying to do. People don't really know for sure how we're supposed to deal with all these health disparities and health equity issues from a research standpoint. But I think that we're learning more all the time, and it needs to be multifactorial. We can't just do better medicine. There's going to be times when we also need to do a whole bunch of additional things layered in to address social determinants of health that we know are important in affecting outcomes. And if we care about the whole region and the whole population, I think this health system and others know that we have to do that. So Logan, you can just jump in and I'll just whip through some of the data. I've got some good news and some bad news. So this is one I showed last week too. Over on the bottom right, you can see Wyandotte County still has an extremely high rate of cases per 100,000. But there's some great new efforts going on in town. This comebackkc.com effort that the health system here is involved in, and some of the local health departments, is one effort to really try to turn these things around. Next one, Logan. Really, the next 3 of these show the positive things we're seeing in Wyandotte. So we've really got the cases on average moving down. Next, the deaths down significantly in terms of rolling average. Next one, Logan. The percent positivity has gone down significantly, which is great. We hope it stays down. We had a little bump this week there at the end. Next one. But the bad news, right, are some of these issues that are being well publicized. This was an article that just came out this week in New England Journal showing that hospitalization and mortality rates among African Americans in a system in Louisiana were significantly higher than the population percentage there. Logan, why don't you jump down to like slide 12, if you would. I have a whole bunch of Kansas data, a whole bunch of Wyandotte County data. It shows some of the impact of things like the meat packing plants. We've had high numbers of Asians in our county and really across the state of Kansas, as well as high numbers of Hispanics coming positive. The death rates, though, still tend to be disproportionate among African Americans in what we're seeing in Wyandotte County. If you could go to 16, Logan, I want to talk a little bit about what we think some of the causes are of these problems. Some of these same causes are the causes of all the health inequities we see with all sorts of diseases, not just infectious diseases. But with COVID, we know minorities are more exposed because they're living in more densely populated areas. There's really good research showing that historical housing segregation has caused some problems like this. Multi-generational households where people get exposed to each other, as Dr. Brown mentioned, higher use of public transportation, higher involvement in essential industries and public-facing industries by groups like African Americans and Latinos are an issue. We do know that there's higher levels of chronic disease in these minority groups, but there's also pretty good research showing that things like societal race tension and other issues like that can lead to chronic and toxic stress. There's something called the weathering hypothesis that talks about how in some communities this sort of constant stress maybe sets you up for things like chronic diseases, and we even wonder if it sets you up for things like worse COVID-related outcomes. So the next one, Logan, this is the sort of schematic of what we've been trying to do in Wyandotte County. So Wyandotte County is not the best funded public health department in the world, and a lot of public health departments aren't. But we knew we needed to do what the blue box is all about here in Wyandotte County with COVID. So we started sort of fighting early on to do things like more testing, to do as much service provision as we could for things like food insecurity out in the community, not taking no for an answer when we felt like there might be difficulties in getting things done that we wanted to get done. And then we're big promoters of this sort of yes philosophy too. If you work in a public health department or some other social service agency, the one in the middle here is the image of El Centro, which is a really great Latino-facing social service agency in our region here. You really have to be a yes person to deliver more service to these people. And I think our healthcare system is trying to do that in a lot of ways too, in terms of supporting community-based testing and developing the trust and empowerment that we think leads to better health. I won't get into all the details here because I've probably already taken too much time, but a sense of urgency, a sense of service, and really just sort of putting your shingle out there saying that you want to reverse these health inequities is something that can have impact. And we're going to see if that works for us in Wyandotte in the coming months. We're very hopeful it does. If it looks like the data is going the wrong way, we're going to adjust on the fly. So thanks for giving me the time to talk through that. And please join at 10 if you want to see more details. And we've got great regional speakers from Missouri, from Nebraska as well.
Alan, thank you, and you have a great heart, and thank you for being a part of that discussion. So with that as our opening part, let's see if there are questions from our media. And Jill, I bet there are some other questions out there in the public already.
We do. In fact, one of them is, if someone is tested positive with COVID and they live in one of these areas, how do you reach them and how do you trace where they might have had contact?
Where to go?
Yeah,
Okay.
it's really, what are the questions? They want to know a little bit more detail about what contact tracing is.
Alan, you have worked hard at contact tracing and make sure that Wyandotte County, to be fair, where other counties may have had more resources or may have said, we're not going to continue to do it, you've been really determined, said, no, we are going to do it. And I think, fortunately, a lot of folks have rallied to your side about that and to the county side about it.
Yeah, again, I think it goes into the same philosophy we kind of said early on. We've got to do this work, whether we have the people and the money to do it or not. We're slowly seeing grant funding come in from the federal level foundations, as really the whole region is. But we had this volunteer force of medical students that couldn't see patients here anyway because of the risks, and they've been amazing. We have a team of about 45 people that do this work. And so as soon as we get a positive case, they start making phone calls to that person. Whenever a test is done, we always get phone numbers, addresses for that individual. So we get a hold of that individual. We figure out who all they've had close contact with anytime to the 48 hours before they became symptomatic with the COVID symptoms. So anyone that's had close contact with them in that time frame, then we get their contact information and start making phone calls to them. And we give them guidance, education over the phone. This can take up to 3 hours with one case to make all the phone calls. And occasionally we even have to do things like get out into the community and do some door-to-door work, because we want to make sure people, not only we know who they've been in contact with and who needs to stay in that 14-day isolation or quarantine after that, but also if they have some needs, whether that's healthcare needs or some of these social service needs, we want to put that in place. So these students are acting essentially like public health officials and counselors and social workers at the same time. And it's been great. I think we're going to see a lot of places hiring more people, and including our place with some of this grant money. But it's an intensive process. So they say you need about 30 individuals per 100,000 population. So at 45 in Wyandotte, we're about right. But across the metro, we're going to need hundreds of these people to do this work.
Chris, you've talked a little bit about those multi-generational families as well, and people in one area. This has to be important as you were thinking about discharging patients in the hospital to make sure that people were prepared for that. What are some of the things that you all were able to do to make sure folks had a safe discharge?
So for me, what I learned very on when you're talking about this COVID, one of the first things I always attempt to accomplish is, what are barriers to discharge? Day one. Identify families, their counterparts that live with them. And then as we go across the stay or the length of stay, we begin to try to figure out how can we navigate those homes. Because as you say, we have multi-generational families, multiple people in their homes. And for example, there have been times where I had a patient, for example, his child had sickle cell. And I said, I cannot discharge you home with that sickle cell child. And he was able to negotiate, get his child to a family member's home who was nice, safe, no COVID. And he was able to go home, isolate himself based upon local health department guidelines, and then bring her back back home when able. So we've had to do a lot of negotiating like that. Identify what those barriers are. Identify what's at home. What are your needs? What can we do? Because we can't rightfully send them home when we know that they have multiple people at home that we could potentially put them at risk, because we are discharging them. Although their symptoms have resolved, we know they still need to be self-isolated, self-quarantined. So those are some of the kind of things that we've had to do from an inpatient standpoint, if that makes sense.
No, it totally does, and thank you. And Dana, I don't want us to get lulled into a false sense of security. It's easy to think, oh, your numbers are down, Wyandotte County's curve is flattened, we're getting better. Yeah. We can take our eyes off the ball a little bit. Let's go party.
Yeah, that's probably not true. Again,
no, Dana, it is not true.
It is not true. We know that early on in China, the China experience, they said, well, maybe just 2% of the population don't ever have any symptoms from COVID. And now that has been a little bit reversed, and certainly the CDC says anywhere from 30 to 35% of people may not ever have symptoms. And those are the people that are dangerous to spread the disease to people who are in the vulnerable populations, because they are feeling well, they don't have symptoms, and then that's how we can get exponential spread, and that's why it's very dangerous.
So, Alan, how do you try and help combat that as everybody wants to get back out into society? What do you do in a place like Wyandotte County, which we know is more vulnerable?
So, again, that's part of that multifactorial approach. I think we know we've got to do innovative and well-constructed communications and outreach activities. So, hitting the airwaves. I was on Spanish language Christian radio yesterday morning with one of our directors of the Juntos Center for Advancing Latino Health. Yesterday, you got to hit social media. This stuff has to be constructed so that it is trusted by people, because some of the communities we're talking about have a historically justified reason for not trusting institutions and large organizations. because of bad experiences people have had. So that trust building is part of doing that outreach, providing those services, looking like you're about helping people and not about keeping track of them, trying to control them. And I think that if we can combine the sort of healthcare delivery with some of this public health science we need to do, I think we can build up a communal effort and have people sort of changing their behavior long term. Even if it feels like a new normal, the new normal is the way to save a whole bunch of vulnerable lives, as Dr. Hawkinson mentioned.
Yeah, such a big deal. All right.
Yeah, we got questions. Here's one. How fast are the test results for meaningful contact tracing fast enough to prevent further spread?
Dana, are those coming back fast enough? And Alan, what do you think?
Yeah, I'm not sure the exact question is. I think the turnaround time on getting our testing, the turnaround time is very good. Certainly it's under 24 hours here at the health system. We also do have relationships with other county health departments that we are helping with as well. So I think the overall turnaround time of the testing itself is really good. It's under 24 hours. And so that helps. And I don't know if Dr. Greiner has anything to add to that.
Yeah, I mean, honestly, the faster we can get the results, the better. So every hour honestly counts because we can start to do that contact tracing work. 2 months ago, it was a disaster because we had private labs that were doing testing for a lot of us, and it was taking sometimes 7 or 8 days to get results back. Things really improved there for a while. We've had a few glitches in the last week or 10 days where we've had some labs that were doing better, and as testing has been expanded into lots of pop-up sites and so forth across the community, we've got issues, but we got to keep working to solve those. I think we feel like in public health, we've got to get them back in 24 hours to do the work that we need to do. If we can't, well, we can't, but 24 is sort of the ideal, but the faster the better.
Clarifying question for Dr. Brown, and I think this is easy to answer, but it's asking, will insurance pay to keep a patient longer because someone at home is at high risk? You might want to just clarify that conversation.
Yeah, that was when you were
weren't
talking
keeping them
about
for
having
days.
to do that.
Yeah.
I'll be creative a little bit.
Yeah. So how do you be creative with today's insurance environment?
Well, I think being creative, one thing I don't think, especially what I've noticed with the COVID, now that we're having COVID, we're not having a lot of issues per se with our inpatient stay because we know it is a real disease. The purpose of us trying to take care of these patients is to get them home or out of the hospital as quick as possible. But we can kind of sometimes navigate those days and allow for us to set up home, etc., what's best for that particular patient and family. Okay, we're luckily here, as you know, from a KU standpoint, we didn't see that surge like we saw in New York, in Detroit, etc. So we don't have to move as fast, and we can move more methodical, and we can think about our steps a little bit better in getting those patients safely home.
But are you talking hours or days?
I would say probably hours. I would say days.
Okay.
Yeah, and we usually can find reasons. I mean, people will have COVID. I don't think we're going to have to run into trouble with
No, and that's
discharge
really what it boils down
or
to.
insurance.
I mean, we don't have issues from that standpoint.
But
That's
that's our
pretty
goal
good.
every day on every patient to get them out as soon as possible.
Right.
get
And
them
as safely as possible. I
safely
mean,
as
that's
possible.
what you're
Yeah.
saying. We have to be
Right.
safe,
We have to
and
be
we have to
safe.
be soon.
Exactly.
And those things have to find a balance.
Exactly.
And I think you've
Exactly.
done a great job of describing. I mean, I think that example of somebody can't go home when their child has sickle cell, and we know that COVID is a disease that can affect blood vessels and inflammation. Oh my gosh, thinking about that just gave me chills a little bit. Like, thank goodness you were there to help them make sure we had a safe discharge. So it really does make all the difference.
We have a question about diversity in Wyandotte County, the percentage. Do you know the percentage
We
of
do.
in
Yeah.
income?
Yep. Income and racial and statistics about diversity in Wyandotte, Alan.
Yeah, so Wyandottes very diverse. I don't have the exact income statistics, but it's one of the poorest counties in the state of Kansas. In terms of racial ethnic diversity, it's about 23% African American, approximately, I think now up to 29% Latino, and then a mix of others. There's a relatively large Asian American population that also is very diverse. A lot of refugees and immigrants from countries all over Asia live in Wyandotte County. So it's definitely one of the most diverse counties in both this metro region and really across the quad state area of Missouri, Nebraska, Iowa, etc.
Large Caucasian percentage in Wyandotte too. What does that run now?
Say that again, Dr. Steiner?
There's still a large Caucasian percentage in Wyandotte County. What is that percentage?
There is, I think it's approximately 45% right now. It's a little hard to tell sometimes because when you're doing ethnicity and asking people about Hispanic ethnicity and then also asking a separate race question, you do get people who answer the race question multiple ways. So you have a lot of folks that would be categorized as Hispanic ethnicity who are also listing Caucasian as their race.
So yeah, a lot of it. I mean, it's a challenging place, and the interesting thing is, and I think this is one of the great things about Wyandotte. I remember there was an article, I want to say it was in the New York Times and carried locally in the Kansas City Star a number of years ago about the I-35 corridor. Wyandotte County turns out to be one of the more diverse counties, not just locally, but in the United States. I mean, it really it's a fascinating place historically and about why people arrived there and how they've arrived there. So I believe that we are joined now by Dr. Carrie Francis, one of our great ear, nose, and throat physicians here at KU. Carrie, welcome this morning, and thanks for being a part of our program. How's your OR case? We'll come back. I'm not hearing from her right now. So just a little follow-up, though, on some of the issues we've been raising. Dana, you've mentioned before that in our hospital, we have different folks, but we tend to have a preponderance of African-American COVID patients. Can you address that a little bit, and how has that been going for us?
Yeah, I think we have seen, that, but also within that, just varying ages. And certainly Dr. Brown could comment on that as well. And, I think here we have been very good about identifying at-risk populations and the patients and keeping them in the hospital when we can, getting them home when we can safely, but then also evaluating about are they further at risk for higher disease or higher level of disease, critical illness. And it's not only the African American population, but unfortunately, it's also the age distribution within there. It's not just the older patients, but it's younger patients as well. And Dr. Brown, certainly
at one
taking care
point,
of a lot
I
of them.
believe 60% of our patients were African American with COVID. I don't know if that still holds true. Any thoughts about that, Chris?
I think obviously it varies, but it's still kind of going around that same number.
Yeah.
And I agree with what Dr. Hawkinson said. I mean, I think we've done a very good job of identifying those patients. We've done a very good job of being very aggressive in how we treat those patients, meaning medically. And also, again, like I've said before, in identifying how do we get them home? What are we doing not only from a medical standpoint, but also from a socially standpoint as well? And we're trying to treat them holistically, not only medically, but also what we have to do to get them home.
Dr. Francis, I think, is now on the line. So again, Dr. Francis, one of our terrific ENT surgeons here at KU. How'd your OR case go this morning?
I hope that you can hear me now, but everything went well. Thank you for asking, and thank you for the invitation.
Talk to us a little bit about what you've seen and learned around COVID illness and your impact from your standpoint on African Americans here in our area and our region.
Sure. I, as you mentioned, I'm an otolaryngologist, so I am a subspecialist, and I don't see our COVID patients in the same capacity as some of our frontline healthcare workers. But as an informal student of public health and advocacy, something that I took as a challenge for myself a few years ago, it has been important to stay informed and abreast of the issues that are happening around COVID, our communities, and the disproportionate impact. So I think we have so many scholars nationally, scholars on our campus, certainly the folks that are on the line today that are talking about this and writing about this. I feel that one of the most important things that we can do is definitely use our data and use it wisely. So as not to put the burden on our patients to fix inequity or promote ideas such as race-based medicine. So a collaborative approach to making sure that we see our patients, that we address the structural impact that has created the inequity that we see now.
Yeah, it is. That is so true. There are so many things that feed into the inequity around this, and it was really a public health crisis. So,
What is the safest way that someone can help with the inequity going on in Wyandotte County around COVID? What's a safe way to help?
what's a safe way to help? Alan, let me first turn to you because you're with the county health department, then we'll open up to our panel.
So I talked a bit about this sort of philosophy of service and saying yes. And there are lots of safe things people can do. People have been sending us masks in mass at the health department, which we love. We've been distributing them out to churches, community groups, those kind of things. There are lots of public health departments like ours. You can go to the website and click a volunteer button, and they'll start setting you up with things to do, whether it's making masks or helping with coordination of activities, getting involved with some of our partner institution groups, like I mentioned, El Centro. There's a number of other great groups that like harvesters that are doing all sorts of food work. There's a group down in Armourdale that does great work as well. So just look for opportunities on websites of major organizations. Of course, the health system here has similar options if you go to our website for finding ways to get involved. If we all just provide a little bit, it really goes a long way.
And I think just to say we are closely tied with Vibrant Community, Vibrant Health, a federally qualified health center here in Wyandotte, and that's been an important part of the testing efforts and care efforts. And I know they have a number of volunteer activities too. If you go to the Vibrant website, you'll find some really great opportunities to become involved, and I think a really important organization. I'm biased. I'm on the board at Vibrant, just as a full disclaimer, but they do a great job. And there are other great, safety net clinics and things like that in our community that provide a really important service to Wyandotte County and to our whole metropolitan area.
They have questions around infection now. Why does one person in a family get it and another person doesn't?
Okay, Dana.
Yeah, that's a great question.
Yeah, what's up with that?
We don't know. Unfortunately, we have different rates of household transmission, anywhere from 10 to 20%. We just understand that in the larger studies, especially from China, which were published first, and hopefully as we get more from the United States in our experience, but we understand that it's probably 10 to 20%. That's a good thing. We don't really know why, because you are obviously in a household, close contacts. You're probably sharing utensils and spaces. Things of that nature, but we don't exactly know why, but we do understand approximately what the attack rate is per household.
So Carrie, I know one of the things that ear, nose, and throat physicians have been considered the highest risk medical specialty for transmission of COVID because you all operate on the sinuses and the mouth, the face, et And talk to us a little bit about some of the things that you guys have done to make sure that you're safe, patients stay safe, and staff stay safe. And what I really wanted to do is just help our audience understand that it is safe to go in the hospital. Talk to us a little bit because, again, you are the highest risk medical profession.
Absolutely. First and foremost, we are in line with the policies that have been set forth as far as social distancing and proper hand washing, all of those things that play a part in safety. We have protective equipment that we are using for those higher risk cases, and we are ensuring where we are testing our patients, as has been talked about, I'm sure, prior to surgical intervention. So we do feel very comfortable with our patient population getting back into the clinics, and we feel comfortable that we're not only protecting ourselves as surgical providers, surgeons, and physicians, but also our OR team, our staff, and our clinics.
Yeah, and I think it's important because you guys have had to do extra precautions in the operating room, and we haven't had a transmission from a patient to a staff nor vice versa in our health system. I think that's been really remarkable. So, okay.
Absolutely.
Should we be afraid of a vaccine being rushed to market?
Oh, are we worried about the vaccine getting out too fast, Dana?
Yeah, I wouldn't say we should be afraid. I think we should be cautious. We understand that the NIH is doing their due diligence. The utmost importance for them is safety. After that is efficacy. They are working on it. They are doing it rapidly, but still under tight constraints because of those two features. So I don't think we need to be afraid. I think just cautious. There is cautious optimism now because of those early studies as far as possible efficacy as well as safety, which again is probably the most important thing. So I think moving forward, we are, and the NIH is being cautious. And I think we just continue to do that and we're just trying to be a little bit more efficient in the way that we're studying this and the timeline.
Alan, I know you're going to be a big proponent of vaccination. Thoughts about this question as well?
I totally agree with Dr. Hawkinson. We've got to establish safety. We've got to establish efficacy. And then one thing we've really got to start thinking about now, even though we're definitely some months off from having something that's safe and effective, how do we distribute it? How do we get it out to the community as fast as possible? We know from prior new vaccine distributions, it could take months to do that. So if we can get organized now and be thinking about what's the way to promote it, what's the way to get community buy-in, what's the way to route people to the right places to get those shots, we can save a lot of lives that way too.
I think it'll be really important. That'll be a subject I'm hoping next Friday. We may have a special guest. We'll talk about that next week. But we may have a really special guest to help us address that. You know, one of the things about vaccination is that part of it is that if you're inventing a whole new way of doing a vaccination, that's one thing. If you're using something that's a little more tried and true, which has been the direction of some of the things so far, then you can establish better safety. If there's actually, and you have to have a little bit of a medical background, but some of it is still really good. And some of the picture, the New England Journal of Medicine last week had a really nice article about where we are around vaccine development. And I think the important point is, I believe the coronavirus section of the New England Journal is still open access. And so if somebody wanted to really dig into that question, you could look at that. And I think it would translate reasonably well. It does have some pretty heavy medical terms in it. But Chris, once we do have a vaccine, we still have to get people to trust it. And sometimes minority communities don't always trust these kind of new developments.
That is true.
What do we think?
That's a tough question.
I know, that's why I asked you.
That's a very tough question.
Myself, actually, so
Yes. No, that's a tough question. And I think we just have to educate, re-educate, don't give up, continue to communicate the necessity, the importance, the safety, and how it can prevent further disease spread and illnesses. I mean, that's the best way I can put it.
Well, and I think historically, and Alan, you'll know this, I'm sure, when you talk about different communities, you can't just go the standard way. You have to go to places where those communities have trust. Yes. And so I know in Wyandotte, we have worked through African American churches or El Centro or other areas. Talk a little bit about how the health department approaches these type of educational activities.
Yeah, so I may have mentioned this before. We put a health equity task force together a couple months ago with members from some of the most underserved sectors of the community, and we said to them, how do we get more people to seek out testing? Because we felt like we weren't getting people to come to the health department or to the clinics or even to here to KU for testing. And they said we have to go to the organizations that are trusted, and we need to set up in their parking lots, and that's how we need to test people. So we've been doing that for about 2 months now, and we've any given day we've usually got 2 or 3 of those pop-up testing sites going across the community. You can go to our ykck.org website and find them, and most of them are open every afternoon. Before we did that, we weren't getting the testing volumes we would have expected, especially if you look back at those early clusters we had in some church communities, in some nursing homes. We knew we needed to test more people. That's really turned around, and it's thanks to that group telling us what to do, and instead of us expecting people were always just going to come to us.
You're saying that listening is often more important than talking at people.
It is. That's why I need to cut down on the slide volume.
Yeah.
Sorry.
Yeah. And you need more different tools.
Well, I agree with what Dr. Brown and Dr. Greiner have mentioned. I also think it's important that we acknowledge past injustice, which has really created a sense of distrust. And so it's important that we acknowledge what has happened historically. And we are accountable to our community. So I think that is important as well.
Yeah, and we see that playing out in the country. Last night was a tough night, and a lot of it is centered around past but ongoing injustice, which leads us to some of the difficult events that we're seeing unfold in multiple communities in our country.
There are questions that are kind of around topics we've discussed before, and they want to know how this is impacting Wyandotte County. Topics as if kids aren't coming in to get their vaccines, if people aren't seeking health care for a stroke or for their other illnesses. Are we seeing any kind of uptick in that from the county?
So really, I'm going to paraphrase that question, because I think what the driver of this is, because of a lack of trust or historical inequities, injustice, and other things, are people getting sicker while they're sick and before they come get care? Chris, thoughts about that?
I agree. I mean,
and you said that last one time you were on our program about folks from minority communities tend to be sicker in our inpatient settings.
They do.
Not just with COVID, anything.
Yes, anything. We take care of a lot of sick patients. They typically will, for various reasons, stay at home and allow the disease to force the presentation, meaning they get to a point where they can't physically function, thus they present to IED, and the acute of the illness a lot of times is a lot worse versus where they would have received health care, or at least attempted to receive that health care early on. And again, there are a lot of barriers, based upon, my public health background. There's a lot of barriers that we can sit here for hours talking about, but we do see our minorities present with worse scenarios than our other counterparts.
Carrie, you mentioned historical injustice, and clearly that has a major role. What can be done, do you think, to help build trust between our health system, or really any health system, and a community that doesn't trust because of that injustice?
As I stated before, I think acknowledgement is definitely important. And as you mentioned, community engagement, but certainly community accountability. So when we create policy, when we develop norms and practices, we are accountable to the community. So what conversation has happened? Are community members a part of those policy decision-making meetings? And I believe that is really where we begin to heal as well as work together for a different future. But community accountability is really what I go back to often. And as Dr. Brown mentioned, there are so many structural barriers, but we also have to consider that when we see patients, African-American patients or other patients of minoritized communities who present sicker. Do they have to present sicker to get care? Do they have to present sicker before they are tested? So all of these things play a part into how disproportionate results, how disproportionate data and disparity is perpetuated.
Please.
And this, unfortunately, makes Alan's job a lot harder. But, as you mentioned, Wyandotte County has a vast, the minority population is just not a minority population, meaning it is a vast, a lot of minorities, Asians, different ethnicities, correct? We also have to realize that one model does not fit all. We have to adjust and educate each one of those individual minority sets, African Americans, Asians, etc., in different ways, Hispanics. It really is a very, very daunting task. And it's not just a one fit, one all, which I guess that makes your job a little harder. But, think about these health disparities and how we address the minorities and getting them into the hospital and taking care of them.
And I would suggest you go tune into Alan's website or program later today, because I know he's got slides about this.
I do, But there's also great examples. I mean, Dr. Francis mentions that this stuff is real for these communities. I mean, Japanese internment happened in World War II. Tuskegee happened. You know, Hurricane Katrina happened. We've got the public charge policy in this country is affecting how Latinos access and engage with everything, and it's real stuff. So we need to think about ourselves as accountable for not necessarily reversing all those things directly, but by providing as much as we can so that the trust level is as high as possible, listening to people, letting the people out there in the real world drive some if not most of our decision making, hiring people that understand the community and can get out there into the neighborhoods and do things. And then again, it sounds simple, but just saying yes more often instead of saying, oh, I'm not sure how I do that or how we're going to do that has been something that I feel like has been very useful in the community engagement work that a number of us here have done over the years in the local diverse communities.
Yeah, so important. Well, it's probably time we begin to wrap up our program today. I know there are a lot more questions out there. We'll try to get to those in the future or after the program. Dr. Francis, any final thoughts today?
Well, I do want to say again, thank you for inviting me to the conversation. I do believe that this is such an important part of how we move forward. Coronavirus has certainly exposed or reflected societal inequity that has always been in place. And this is a great opportunity for us to really sit down and think about the best way to move forward. I think that what I rely on is a quote from Dr. Brian Smedley, and his statement is that health is produced outside of the clinical environment. And I think that's so important when we talk about patient engagement, we talk about community accountability, and how we as physician advocates move forward to heal.
Yeah, I think that's well said. Chris?
I think she said it.
Ditto. Pretty darn well,
Ditto.
right?
Thank you.
Yes.
And thank you for having me.
Yeah, you bet. Alan, any final thoughts this morning?
Yeah, that advocacy Dr. Francis mentions is important. We all do that in healthcare, and I think we take it seriously. But I think we can all be advocates for equity, and as a society, if we're trying to get over COVID, we better be advocates together and unify. So let's all keep working toward that.
Dana.
Yeah, I'd certainly like to echo what Dr. Brown, what Chris said before, educate, educate, educate. We here at the health system don't care what color you are, or what ethnicity you are, your socioeconomic status. Our goal is to educate you with the most up-to-date, accurate science so you can make the most informed decision. Because as Alan said, our goal is to gain your trust to keep you and your loved ones safe and healthy, and when you are ill, get you better and get you back home.
You know, you've heard me talk about those 5 rules. Number 1, save the patient. Number 2, do the right thing. Number 3, do no harm. Number 4, number 5. Here's a story. So, you know, I'm a white kid. Grew up in Independence, Missouri. Some privilege in Independence, Missouri. Went to Truman High School. Went to med school. Met my wife there, a Princeton graduate. She's smarter than I am. That comes as no surprise. My wife's African American, and my kids are biracial. You know, seeing the world through their eyes is much different than seeing it through my eyes. We have to do the right thing. And politicizing a pandemic is not the right thing. Recognizing that the pandemic highlights racial disparities and injustices in our country is the right thing. And then, as Alan said, stepping up and trying to do something about it, that's the right thing. I had a text last night from one of our outstanding physicians here. She writes, "This may or may not be your platform, but I have staff grieving over the George Floyd travesty. I think some speak to that issue would be welcomed. I am sickened." I'm sickened. We should all be sickened. Because these kind of things make us all ill. I wrote back, "If only this were one isolated event, but racial intolerance is not isolated and continues to occur because as a society, we have given it permission to do so. We are all responsible. We have to do the right thing." We'll see you next week. Thanks for being with us.
question, but it's educate.